tasked with completing the lecture on HER2 positive breast cancer and really emphasizing the neoadjuvant as well as the adjuvant approaches. Here are the just very simple bottom line in terms of the incidence of HER2, at least in the United States. It's about 1 in 5 breast cancers are HER2 positive. And as we all know, it's important that all people with breast cancer be tested for HER2. While it used to be considered prognostic in a very bad way, HER2 positive disease associated with a poor prognosis, even when matched for stage and tumor size, for example. Right now, it's actually not prognostic, but it is exceptionally predictive for benefits on anti-HER2 treatments. So the first question, and this is a nod to the pathologist in Bangladesh who I've enjoyed conversing with, but an area that has become exceptionally complicated is the definition of HER2 positivity. We can detect HER2 based on both in immunohistochemistry as well as in situ hybridization. You'll see 3 different methods discussed. So IHC doing antibodies directly applied to tissue for direct visualization with light microscopy. Chromogenic ISH or CISH is where the targets are labeled. You don't need special equipment. It's a bright field microscopy that lights up the ratio, and then FISH, which is fluorescence. In terms of the probes we use chromosome 17 because HER2 is on chromosome 17, and then a pink probe. And what we're looking for is the ratio in ISH between these two. And on the right, you're seeing both a normal as well as an amplified HER2. Now, this is a definition per the National Comprehensive Cancer Network, and it's not as simple. I have to admit, every time I see a patient, I'm looking for IHC3+, because it actually makes it exceptionally easy to call it HER2 positive. If you get an IHC2+, then you must go to in situ hybridization, and there are multiple ways that someone meets criteria for becoming HER2 positive. And as you can see, there's 4 groups where HER2 positivity is now defined. So this really speaks to the expertise of pathology when it comes to determining HER2 status for us clinically. And again, I often will need to look this up, but I also will need our pathologists during a tumor conference to go over this on each and every patient who they're calling HER2 positive based on ISH. So the bottom line, all people with HER2 positive disease require treatment with an anti-HER2 agent or Trastuzumab. This is the meta-analysis that was presented now 9 years ago. So there should be an update by Cochrane's group. But looking at Trastuzumab applied in early breast cancer, although it also included locally advanced disease, it included studies in both the adjuvant as well as the neoadjuvant setting. These were the 8 randomized trials that were included in the meta-analysis. So B31, BCIRG, the single center study from MD Anderson, which was a neoadjuvant trial, FINHER, HERA, 9831, NOAA, and PAX-04. Now, what I've noted here in this table is who was actually enrolled, whether they required node-positive disease. If you look at the MD Anderson study, you had to be stage 3A. And what criteria was used to determine high-risk node-negative disease. Now, the size criteria oftentimes switched. If you see here in 9831, the size criteria was dependent on whether or not you were also ER negative. Here's the intervention which was used, which was either AC-based therapy followed by either Taxotere or docetaxel with Trastuzumab given weekly. Some studies used FEC. Some studies like HERA enrolled after chemotherapy completed. So this is a purely maintenance trial testing 1 or 2 years. And then some use both concurrent and sequential. So importantly, I've noted here whether or not the design was to test chemotherapy with Trastuzumab followed by some form of maintenance, or if it was chemotherapy followed by Trastuzumab in sequence. Again, also noting duration and what the comparator arms were here. So here's the bottom line in terms of disease-free survival results. This should be not new news to all of us, but in total, with studies that were slightly heterogeneous, okay, so the I-squared points to whether or not these were very similar or different studies, usually an I-squared over 25% with a significant p-value, gives us some pause in terms of over-interpreting the data. The suggestion here, although it met a confidence interval, is that we should be giving trastuzumab. Trastuzumab is associated with an improvement in disease-free survival. In terms of overall survival, you are seeing complete homogeneity in the results. The I-squared is 0. And although the p-value is 0.45, it borders on significance. It is not, it's still important results. Things that we can more rely on is that trastuzumab given in the adjuvant or the neoadjuvant setting is associated with improvements in overall survival. Does the duration matter was one thing they also tried to answer in the meta-analysis. They looked at treatment if it was less than 6 months or greater than 6 months. And they're seeing, again, with an I-squared of 0, that sequence does matter, or that duration does matter, that greater than 6 months is better. Does it matter if it's sequential or concurrent? Again, you're seeing a significant p-value here favoring, in this case, it was concurrent. But this also comes at a cost. So this was the risk of heart failure across all of these studies. Again, all of them received some form of an anthracycline, whether adriamycin or epirubicin. You are seeing a hazard rate, or actually it's a risk ratio, so a 5-fold increased risk of heart failure if you gave trastuzumab. So all of this really states that it's exceptionally beneficial, but there is a cost. So it does matter to us not to use these drugs in a very haphazard way, and that we need to pick our patients very carefully in order to give those patients that survival advantage and minimize the risk of excess toxicity across a whole population. So in summary here, HER2 is essential, and that the regimens that are used in the adjuvant setting are appropriate in the neoadjuvant setting. Maintenance treatment is a part of the treatment plan. So everyone who gets chemotherapy concurrent with trastuzumab should finish some maintenance trastuzumab. So here's a case for you, 45-year-old female who presented with a breast mass that was growing over the past 2 months. She was recently pregnant, but noticed that over the past 3 to 4 months, the baby was refusing to latch onto her breast. No significant medical history, but her mom did have breast cancer. Imaging shows a 4-centimeter breast mass, and an X-ray ultrasound showed enlarged adenopathy. Biopsy shows an ER/PR negative, infiltrating ductal carcinoma, HER2 neu is 3+ IHC, and the axillary FNA is positive. So in a 45-year-old female, as a medical oncologist, I can tell you I would be talking to her first about her desires in terms of the breast surgery. Does she want to keep her breast? Does she need a mastectomy? Is she willing to undergo a mastectomy? Given her family history, she needs genetic testing. What would she do if she was found to have a BRCA mutation? All of this is very important because it's going to inform the question of whether to proceed with preoperative or neoadjuvant chemotherapy or to proceed directly to surgery and do chemotherapy on the adjuvant side of things. So here's my take on neoadjuvant therapy in breast cancer. Remember, all of our clinical trials have shown one clear endpoint, that it facilitates breast conservation on people who need to undergo mastectomy due to the breast cancer presentation. We are now also understanding that for patients who have nodal involvement at presentation, neoadjuvant chemotherapy can spare them an axillary node dissection. And we also know now that it is highly effective therapy for some breast cancers, but not for others. Specifically, it works exceptionally well in HER2 positive and and triple negative disease. So according to the National Comprehensive Cancer Network, candidates for preoperative systemic therapy have inoperable breast cancer, inflammatory, clinical node N2 or N3 disease, or clinical T4 tumors. But for those patients who are operable, HER2 positive, triple negative, with a clinical tumor size of 2 or greater, or node positive disease, a large tumor to breast ratio in a patient who desires breast conservation, because node positive disease clinically can become node negative with preoperative systemic therapy. So again, nothing here points to mandates that patients with ER negative or HER2 positive disease must get neoadjuvant therapy. This is still an individualized decision, and the first break point is what is the surgery she is facing and what is her willingness to proceed with mastectomy if that's the recommendation. What do we know about neoadjuvant chemotherapy? There was a very nice article just published in Clinical Cancer Research in 2020. It was an individual patient meta-analysis with almost 28,000 volunteers, 51% of whom enrolled in a randomized clinical trial. This is a figure that I think we can use. Overall, for breast cancer, 1 in 5 will achieve a pathologic complete response. That figure is 10 percentage points higher in HER2 positive and triple negative breast cancer. Hormone receptor positive disease, it is 1/3 as effective. Less than 10% will achieve a PCR. It also shows that PCR is associated with improved survival outcomes with a hazard ratio of 0.3 for event-free survival and an overall survival advantage of 0.2. PCR predicts positive outcomes. In terms of HER2 positive, triple negative, and hormone receptor positive disease, this is the 5-year event and overall survival rates for those who got a PCR versus no PCR. 5-year event-free survival rates, 20% percentage points higher for HER2 positive disease, almost 40% higher in triple negative breast cancer, less than 10% of a benefit in hormone receptor positive disease. So the benefit of PCR, even in hormone receptor positive disease, is not as great. In terms of overall survival, substantially better outcomes with a PCR with HER2 positive and triple negative breast cancer. Not so much of that benefit seen with, again, important statistics when we counsel our patients about the use of primary chemotherapy for breast cancer. So in terms of our HER2 treatment, for such a long time, all we had was Trastuzumab. You had a lecture earlier about metastatic breast cancer. We have gone multiple places with this. There are drugs still in development. Here's Pertuzumab, which blocks the hybridization. Extenet, which within the cell AF binding. There's Lapatinib. There's potentially additional effects by downstream targeting with Alpelisib and the CDK4/6 inhibitors. Here's Neratinib. So again, multiple agents. Where do we use them all? In terms of neoadjuvant chemotherapy, what you'll note in the NCCN guidelines, adjuvant and neoadjuvant regimens lapse. So any regimen you would use in the adjuvant context is reasonably for use in the preoperative context. You will also note most of these regimens still contain a Trastuzumab, Some contain carboplatin, or actually this is cyclophosphamide here. Carboplatin has not yet really been recognized as a preferred regimen in HER2 positive disease, but are incredibly important. Okay. So where did we get this role for pertuzumab, particularly in the neoadjuvant setting? Multiple trials that have been conducted. This is another nice systematic review in 2020, looking at the studies, and I'll just note here the PCR rates go up with the incorporation of pertuzumab and trastuzumab. In Trifina, they looked at the regimen of carboplatins incorporation compared to anthracyclines, showing similar results. Here was a sequence of effect followed by carboplatin, paclitaxel, Herceptin, trastuzumab, showing an improvement in pathologic response rates. So again, much activity trying to figure out how to improve on outcomes. Chemotherapy, whatever the adjuvant is reasonable in the neoadjuvant setting. We do incorporate pertuzumab with trastuzumab for better outcomes in the neoadjuvant context. But remember, chemotherapy is only one part of how we would treat HER2 positive breast cancer. The second part is, do they all get trastuzumab for a year, or should we be looking at that too? And why is that important? So the question here is, for people with HER2 positive breast cancer, does the pathologic complete response matter? We have shown that it does improve event-free survival by an individual patient meta-analysis, and there's definitely an improvement in overall survival. Here's another analysis of 10,000 people treated on one of 9 clinical trials. What they found was there's an increased risk of a local regional recurrence with the following factors, which all came out as significant on multivariate analysis: younger age, node positivity, high grade, non-PCR, and triple negative disease. They all predicted local regional recurrence. For HER2 positive disease, comparing PCR versus non at 5 years, there was also a stratified difference based on whether or not someone was ER positive or ER negative. So you're seeing here 3.1 versus 4.8% for PCR, but for the non-PCR and hormone receptors negative, that rate was almost 15%. So the Affinity trial was a treatment that looked at the question of maintenance pertuzumab and trastuzumab versus placebo and trastuzumab following chemotherapy. These were patients who were not treated with neoadjuvant chemotherapy. They all received chemotherapy plus tras, and then the randomization happened. Again, you're getting this definition of high-risk disease as being node positive, node negative, but at least 10 millimeters, node negative at smaller tumors if ERPR negative, less than 35, or high grade. And here's the Affinity results comparing pertuzumab, trastuzumab, or trastuzumab plus placebo. Straight line in the patients with node negative disease. Slight difference here if you had node positive disease, which achieved statistical significance, but no significant intent to treat. With Affinity, we are now able to do that stratification where we are more inclined to offer combined anti-HER2 treatments in high-risk disease, or those patients with node positive disease. Again, so that was going from people with a quote PCR. What about if you don't PCR? This is the group that we're all concerned about. Again, multiple data that I've presented showing that their outcomes are not as good. PCR. A lot of work, a lot of clinical trials. So these are who were treated with therapy for HER2 positive disease, and they did not achieve a PCR, which was defined in this trial as residual disease. Overall survival, distant relapse-free survival, as well as safety. What they report in terms of mortality, we are keeping them from having a relapse event. What about go on maintenance trastuzumab, HER2? A study that was very controversial. It was controversial. EXTENET trial, we looked at women with HER2 positive breast cancer stages 1 through 3 who completed adjuvant trastuzumab within 2 years. So they could have stopped it for completion of 1 year and then monitored and still been off therapy for an additional year. They were randomly assigned to neratinib, placebo, and at 2 years, invasive disease-free survival with neratinib was 94% versus 92% with placebo. This is what the curves look like when the study was finally published. Again, statistically significant. Talking about less than 3% absolute improvement outcomes. Some people do routinely offer it in high-risk HER2 positive disease. Others do not. My take is you need to review the patient and come to a decision alongside your patient, because these data to me don't speak towards a recommendation for everybody. Here it is in terms of hormone receptor status on EXTENET. As we're seeing, it does appear that HER2 hormone positive breast cancer is different biologically from HER2 positive hormone receptor negative breast cancer. In the case of extended maintenance neratinib, the benefit was seen in hormone receptor positive HER2 positive breast cancer, but it was not seen in hormone receptor negative breast cancer. Now, why is this important? We could talk about the benefits, less than a 3% advantage, but some young patients with hormone positive disease may want that extra protection. Neratinib is not a mild therapy, as we'll see in one moment. So with the EXTENET trial of adjuvant neratinib, if you look here, 40% of patients experienced grade 3 diarrhea. An additional 33% had grade 2 diarrhea. So the majority of patients had issues with diarrhea. Okay. This can be very significant, as we all know, even with grade 1 symptoms. So the control published just recently in Annals of Oncology looked at several ways to control diarrhea. They looked at loperamide by itself with budesonide, cholesterol. And what they found was whatever you did to prophylax and control it was effective. So you could take that 40% grade 3 or that 77% severe toxicity, and you could reduce by at least 10% percentage points. But, if you look at the patients who had no diarrhea, you could actually increase that proportion by 3 to 4-fold. So again, if we use neratinib, jumping on the management to prophylax against the diarrhea is exceptionally important. So here we are in terms of how to approach a treatment after preoperative systemic therapy, and I'll get to the HER2 positive cohorts, which are in the middle here, if there's a path CR, we're recommending trastuzumab with or without pertuzumab. Either way is reasonable, okay? If you have a residual disease in the tumor or in the node, we are now recommending TDM1 for 14 cycles. And if you cannot do TDM1, we are recommending Traz with or without pertuzumab. And we're adding it. Trastuzumab with pertuzumab is no longer the first consideration. We are using TDM1 for 14 cycles here. You will also note that in the follow-up is where the neratinib discussion comes in, but it is not considered as part of, quote, the adjuvant context. Here's another case, 45, underwent her first screening mammogram, no past medical history, mom had breast cancer, and now she was found to have an 8-millimeter breast mass. Actually, ultrasound was negative. Biopsy shows a grade 3 infiltrating ductal cancer. ERPR is negative. HER2 new IHC is 3+. The surgeons tell us she is a candidate for breast conservation. So the question is, should we give this woman neoadjuvant chemotherapy? Should neoadjuvant chemotherapy be administered to all patients with HER2 positive breast cancer, regardless of size? This is actually an area of controversy. I know many of my colleagues are exceptionally optimistic about the use of neoadjuvant chemotherapy in HER2 positive breast cancer. I'm not as optimistic, and I'll explain why. So the reason why I am not optimistic about using it is because we have data on dose de-escalation after surgery. So this is the APT trial, the adjuvant paclitaxel and trastuzumab. No carboplatin, no anthracyclines. These patients had a T2 lesion up to 3 centimeters and node negative. They went to surgery and they got paclitaxel plus trastuzumab followed by maintenance trastuzumab for these limited breast cancers. There was no comparator arm. This was a phase 2 experience. What we know going out to 7 years is that breast cancer specific survival is 99% in these patients. Here you have disease-free. In C, I thought it was interesting. They're showing that it didn't matter if the tumor was 10 millimeters or larger, or larger than 10 millimeters or 10 millimeters smaller. And it didn't matter if they were hormone receptor positive or negative. So these results say you can dose de-escalate HER2 positive therapy for small cancers if they are removed first. The ATTEMPT trial was a second trial from the same group, which sought to look at TDM1 in that population versus the APT treatment of paclitaxel trastuzumab. So it was a 2-to-1 randomization. About a third of these patients had a T2 or T1C lesion up to 2 centimeters. Over half had high-grade disease, hormone receptor negative, and about a quarter. But if you look here at what happened, the discontinuation rates were double with TDM1. And in terms of disease-free survival, by hormone receptors and tumor size, it was essentially the same with TDM1. Okay, showing that patients with small tumors do well. Okay, so whether or not they require that chemotherapy, TDM1, or the exposure to that toxicity remains to be seen. I am personally not using TDM1 in this setting. So these data suggest exceptional outcomes with adjuvant therapy for small tumors. If you took the patient to neoadjuvant therapy, you are committing them, in my opinion, to the best treatments we have in the absence of full pathological data. So these patients would get AC followed by THP, Taxol, Herceptin, pertuzumab, neoadjuvantly prior to surgery, and then maintenance trastuzumab. That is significantly more therapy than what APT tells us is necessary. So people with small HER2 positive breast cancers who undergo surgery do exceptionally well within a de-escalated adjuvant regimen. Because the primary objective of neoadjuvant chemotherapy is to offer breast-conserving treatment for patients who require mastectomy, you are removing the primary objective of giving primary chemotherapy. Those who are not patients, these are not the patients who will require standard treatment prior to surgery. So what is the benefit of PCR in a group presenting with a tumor size less than 10 millimeters? Okay. So in the bottom line, the way I think about this issue is if you commit someone with a small breast cancer to neoadjuvant therapy, you are therefore committing them to more intensive treatment, which is likely never to have been necessary had you taken her to surgery prior to treatment. Okay. And this is the other thing, just recalling here in terms of the benefits and the risks of the toxicity here. This is what happened with carboplatin, Herceptin, pertuzumab in women with at least a 2 centimeter tumor. These are not trivial side effects. This is what we would expose patients with small breast cancers to if we gave them primary chemotherapy prior to surgery, rather than surgery followed by limited chemotherapy of 12 weeks with weekly paclitaxel and trastuzumab, followed by trastuzumab alone. Remember also, neoadjuvant chemotherapy by the meta-analysis exposes women to a 5-fold increased risk of cardiac disease if an anthracycline regimen is used followed by trastuzumab. That is also the risk you will expose to people who have small breast cancers that are HER2 positive. So I even asked, this is way back in the day, but I asked, on Twitter, how anyone would treat a 4 millimeter node negative cancer that was triple positive. Okay. And this is going beyond APT, right? Because APT says you don't have to give the anthracycline. But what if it's even smaller? What if it's less than 5 millimeters? And this is actually the outcome. 16% of this group still would give THP, followed by endocrine therapy. 44% would give APT, followed by endocrine, for a 4 millimeter breast tumor. And 40% almost wouldn't give any chemo and wouldn't give trastuzumab. So in the end of the day, over 60% of people would give chemotherapy plus traz to women with a T1A lesion, and 40% would not. So we don't have a good answer, and it's unfortunate the APT trial did not have a randomization towards a control arm of nothing, because I think that would have been, I personally think it would have been ethical because of equipoise in that group, but we don't know. There is a lack of consensus in how to manage very small HER2 positive breast cancers in the United States. So here are my conclusions, and I'd love to get thoughts on this presentation from all. HER2-directed therapy is absolutely critical in the management of upfront HER2 positive disease. So, there's a lot of work going on globally, with many breast cancer advocacy groups who operate on a world stage, that trastuzumab be considered a medically necessary agent for the treatment of breast cancer, no matter where you live in the world. And there's a good reason for it. As we've just noted, it has changed the prognosis of breast cancer that is HER2 positive. These used to be poor prognostic disease that predicted early recurrence, brain metastases, and earlier mortality when matched for tumor size and lymph node status. With the advent of HER2 therapy, with the knowledge that adjuvant trastuzumab-based treatment should be used, HER2 positive disease is now among the best prognostic disease categories in the United States. And I would go so far as saying we are able to cure HER2 positive breast cancers with modern management. This is why we are able to ask questions about de-escalating therapy. When you think about the role of neoadjuvant therapy in breast cancer, whether that be triple negative breast cancer or HER2 positive breast cancer, the first criteria you should be asking our surgeons is whether or not we need to shrink the tumor to allow for breast conservation. All of our neoadjuvant chemotherapy trials, regardless of biomarkers, looked at a primary objective of the rate of breast conservation, the conversions from mastectomy to lumpectomy. We are now asking better questions regarding nodes, whether or not a node positive finding prior to neoadjuvant chemotherapy commits people to complete axillary node dissection following chemotherapy, because we're finding if we can clear the nodes with medical therapy, it is now appearing very safe to start with a sentinel node biopsy and not proceed automatically to an axillary node dissection. But again, the primary objective of neoadjuvant therapy is to improve the surgical options for a patient presenting with locally advanced breast cancer. We do acknowledge that HER2 positive breast cancer, triple negative breast cancer achieves higher pathologic complete response rates. But remember, that has to be balanced, especially for small tumors, with the ongoing data suggesting we are now able to de-escalate therapy following surgery. The reason we can't do Taxol trastuzumab in the neoadjuvant context is there's no 100% certainty that imaging will predict the final tumor size. Okay, so since we can't, take two of the same person, take one to surgery to see what the final pathologic tumor size is, and one take to neoadjuvant chemotherapy based on imaging criteria, right? We are only relying on clinical staging. And for right now, in the absence of any better way to predict all of that, most people would not be using trastuzumab paclitaxel as their primary neoadjuvant treatment for what appears to be clinically stage 1 disease. Appropriate maintenance therapy should take into account disease characteristics and the pathologic complete response rate. So like I spoke about with the NCCN guidelines, as well as the clinical trial data, in the absence of a PCR, the standard recommendation now is not to give trastuzumab, pertuzumab, and not to give trastuzumab as a single agent. We are now using TDM1 preferentially in the patient who does not achieve PCR. But if someone does achieve PCR, there are some considerations on whether or not to give pertuzumab. I discuss it with my own patients, but more commonly, I'm giving them adjuvant maintenance trastuzumab alone, especially if they are hormone receptor positive. And then again, remember, maintenance therapy, whether or not to extend it to the use of neratinib, really requires the counseling on an individual patient level, because some patients will see that less than 3% advantage as clinically meaningful, and others will not. And finally, as I think your talk earlier this evening had mentioned, we are still broadening the options to attack HER2 in breast cancer. And as these new agents become available, we are expanding the adjuvant treatment objectives in our clinical trials. Can we improve on the appearance of brain metastases? Can we find a better agent with less toxicity? Can we reduce the cardiac risk of therapy, which we now know we can if we don't use an anthracycline, which is what's really spurring the development of platinum-based therapies in both triple negative as well as HER2 positive disease.